Hi everyone. In this video, we're going to take a look at the cardiac arrest circular algorithm through the lens of some newer science. So while we're still reviewing that circular diagram, what's new? What's been enhanced? What's made it better? Starting right now. Hi everyone. So looking at this cardiac arrest circular algorithm through the lens of some new science. Well, if you look at the circular part of it, it's kind of centered around every 2 minutes. So historically, every 2 minutes we would stop, check for a rhythm, see if the patient needed to be defibrillated. And what we found is that's just a horrible idea because it limits chest compressions. That whole time, nobody's beating on the patient's chest. Their pressures just tank. Cardiac blood flow tanks, cerebral blood flow tanks. Then we start compressions again. It takes a little bit to build that up, but thankfully in 2 more minutes we're going to stop again. So now continuous chest compressions. We don't stop for any reason. So stopping chest compressions is the first thing. Now, so then it begs the question, well, how do we know if we're going to shock? Enter the use of end tidal, which is in the circular diagram. The use of capnography, waveform capnography preferably. How are we going to use capnography? Well, one, if suddenly it spikes up to 40, 50, 60, that's a great indicator of ROS. What that means is the heart started pumping, it pumped all that CO2 to the lungs, the patient blew it off in one big deluge, and the meter went ding, 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 ding. That's great. On the other side, if it stays less than 10 for like more than 20 minutes, it's kind of the ball game. Resuscitations, that's one of the things you can look at in calling it. A persistently low CO2 despite all our efforts is an indicator of non-viability. Okay, first initiate CPR and it says administer oxygen. And there's been some new work around administering that oxygen in the first few minutes of a cardiac arrest. One method is called apneic oxygenation. And what we would do here is we put a cannula on the patient at 15 liters, maybe have an oral airway in them, but you're giving them high flow oxygen, passive. So the thinking is as we're doing chest compressions, we're creating microventilations. We're still moving air in and out of the patient, although not as much as if they're breathing, but we're still moving air in and out of them. And it seems to work. So in the first few minutes of an arrest, we can choose apneic oxygenation. We can continue chest compressions and administer 1 breath of air every 6 seconds asynchronous. That's another method we could use. So as it pertains to oxygenation, we got a couple different ways we can go there in the first few minutes. Now also inside the circle, an advanced airway. Eye gels are becoming very popular for a reason. They're easy to insert and they work. In addition, we can add an impedance threshold device, the Rescue Pod, which has been shown to greatly improve cardiac flow, cerebral flow. It just enhances the chest compressions dramatically. Again, it's not a respiratory device, it's a pump device. But that combined with the eye gel and the seal the eye gel can create can dramatically improve blood flow during chest compressions. Next, IV drug therapy. In the new science, not so much. In fact, epinephrine has been de-emphasized. In fact, that's the last thing we would do would be to push epinephrine. If we hadn't gotten ROSC, last ditch, we would administer epinephrine. In the current algorithm, 1 milligram every 3 to 5 minutes. There's no max dose on it. But what we did find is that patients who received epinephrine had poor neurological outcomes. Okay, let's scooch over to the boxes over to the right. First thing you see is CPR quality. Couldn't agree more. And all the science points to this, that nothing is more important than chest compressions. That's why we move to a machine as quickly as we can. In the protocols out where I am, get them on a machine as quickly as possible, uninterrupted chest compressions. Now once we have an advanced airway in place, the CPR machine is already working. We can opt to sit the patient up 30 degrees. And this has been shown to be beneficial both in coronary and cerebral perfusion. So consider sitting the patient up 30 degrees. going down to the very bottom right corner, the usual suspects, our H's and T's, our list of causes. Why is our patient arresting? Why are they not getting better? I need to shoot through those very, very quickly. Those remain pretty much the same. This has been just a quick review of the cardiac arrest circular algorithm, again through the lens of some additional new science. My name's Mark, thanks for watching. I'll see you in the next video. Okay, so this is for everybody, those who actually want to look at this algorithm, and in doing so know that it'd probably be better served or have more utility if they printed it on like a napkin, maybe. I shouldn't say that. It's true though.